if I'm a compliance leader or a general leader in a health plan sitting at us, like, I want to fix this. So in the next 90 days, we can't fix everything right away.
People should start. They shouldn't wait for any new audit notice or something else to happen. I don't want it to sit quietly on a shelf, but look deeper into the OIG's Medicare Advantage industry-specific compliance program guidance that was released earlier this year. Look deeper into the recommendations and determine what can you do for an organization your size, whether you're small, mid-size, or large. Because not everyone has the same resources. What can a small plan do versus a large national plan? What can they do to have effective training? One of the recommendations that I would say, because the compliance function has to have effective training in place, you could do attestations, you could do brief tests, you can make it fun, you could do micro trainings. There are a number of ways to get creative.
Something that I took away from this weekend. So thank you for that. So calendar year 2027, it's right now, we're always like operating right now and then planning for the future. Around the corner, one of the biggest friction points I see some teams, whether it's risk adjustment teams, compliance teams, it has so many nuances in itself. We've created this complex system over time because with RADV dropping even more, I think the function of compliance becomes even more critical now in risk adjustment. All right, welcome to another episode of Healthcare STARcast. Today, I'm excited to have my coworker at ATTAC Consulting, Regan Pennypacker. Regan, welcome.
Thank you so much, Subbu. I'm really excited to have this conversation.
Yeah, it's spring. We're recording this conversation on April 2nd. Can't wait for good weather. It's been a long winter, and we are in a very interesting space in Medicare Advantage and healthcare. Overall, which we will dig in a lot and pick your brains in the industry. So before we start, Regan, introducing you and hearing about your journey, for folks who don't know Regan, Regan is a strong industry expert and a great leader in Medicare Advantage and healthcare in compliance. Regan, you built a great reputation over time as someone who understands compliance really deeply, not just as oversight, but as a strategy for the help, for the healthcare organizations that you serve. How do you define your role of compliance in today's landscape?
That's a great question. And to your point earlier, it is a really exciting time to be in healthcare, whether you're in compliance or operations or on the payer or the provider side. It is very challenging and exciting. So in terms of your question, the role of compliance in today's MA landscape, I think having stakeholders that are knowledgeable about compliance obligations that are present. You have to be present in those strategic conversations, having a seat at the table. It's so important because the landscape is changing so much. If you recall a few years ago, the getting was very good for Medicare Advantage plans. Enrollment was steady. There was good competition. There was reimbursement. And, of course, there were the ever-present considerations. We had regulatory audits here and there. It was just a fact of life. But fast forward to now, Subbu, look at what we have today. There are a lot of contracting pressures. There's a lot of provider dissatisfaction. We hear it from the hospitals. We hear it from the providers. Regulatory scrutiny is at an all-time high, and there's a lot of heightened focus on QBPs. So, in my opinion, the voice of compliance, they have to be aware of all of these pressure points that their peers are under to help leadership make informed decisions, not only for beneficiaries, but for the long-term success of the organization that they serve. I think, bottom line, compliance has to permeate throughout the organization.
That's awesome, Regan. Thanks for that context. So with that context, we'll jump into a little bit about you. Regan, I've been learning a lot about you working together, and it's been so fun knowing more about you and the new skills, several new other skills that you also have besides being a compliance leader. So Regan is Senior Vice President of Compliance at ATTAC Consulting Group. She's been both on she was leader at Blues plans and other health plans, and also has been a consulting leader in the past. Regan, walk us through your journey. What drew you to compliance, and how has your perspective evolved over time in the industry?
Yeah, for sure. I can talk a little bit about what's evolved and what hasn't evolved, right? What has evolved are leadership priorities. Starting in Medicare Advantage in the late 90s, I went through a number of different types of leaders, and they all had different priorities. Whether, it was financial was the higher priority, or something strategic, or moving into a new market. And we were under the guise of needing to support them in the best way that they needed their support. Compliance is often identified as the department of no, right? And I think what has evolved is that when you realize compliance isn't over in a corner, and rather they are part of the conversation, and they realize they're one voice, not the only voice, they have to be a partner and understand what the operational pressures are of that leader, or the strategic goals of that leader are. So my journey has gone through a number of different leaders and a number of different priorities. What hasn't changed in my role in compliance is the focus on the obligation to the public. That is the most important obligation, and it's the number one principle in Healthcare Compliance Association. They talk about, the principles, and the obligation to the public is the most important. Over time, my perspective has continued to evolve, but I believe it's only been for the better, because regulations change, administrations change, and being able to ride that wave of change and help be a good partner to providers and payers, that's what makes us really valuable and a really good partner to our clients.
Yeah. As you were talking through, Regan, connecting the dots here, right? I mean, I hear a lot about partnership, connecting providers and payers, obligation to the public, obligation to the members and patients, ultimately who get care, and driving quality care. I see all of those, which is awesome to hear the way you describe the evolution. Speaking of that, what's your mission that drives your work? I know I see it every day when I actually partner with you. When you think about the impact on health plans and ultimately members, how has your mission evolved, and what's your mission right now in healthcare?
I started working in Medicare Plus Choice, now Medicare Advantage, in the late 90s. And at that time, I was in a member-facing role, and I was constantly in reactive mode. People have always been at the heart of my mission. What do we have to do to make sure they understand their contract? What do we owe them as an organization? How can we best help them understand their plan? Moving from operations to compliance was a natural fit for me. I'm a planner. I like cosmos. If you live in a life of chaos, which sometimes operations can be, it's a comfortable transition to go to a place of a little bit more order and structure, and I just naturally gravitated toward it. I'm comfortable in that prevention, detection, correction system that a compliance program requires. I also believe that we have to seek progress and not perfection. And that's what prevention, detection, correction acknowledges, is that there are going to be things that are detected, and there will be things that we need to correct. And that's okay. We simply need to make sure we have a system in place. So my mission really hasn't changed. Fast forward to now, my mother has aged into Medicare, so it's even more of a personal mission and very sacred to me.
That's great. Great to hear. And as we talk about healthcare compliance, risk adjustment, STARs, interoperability, rules, and all those things gets really technical, right? There's so many nuances, but ultimately healthcare is so personal. You mentioned about your mom, aging into Medicare, and I'd mentioned in the podcast before, like my parents, but they live in India, but at the same time in Medicare age. And we go through all of these these personal stories. But what's interesting is stepping back a little bit here. I worked with compliance leaders across in my organization, right? I've worked at in the past. Different people have different understanding of what a compliance leader in a Medicare Advantage, ACA, or a managed care plan do. There are different styles of compliance leadership. In your opinion, what do most people misunderstand about compliance leadership in general?
Everyone has different experiences with compliance leaders. And if you look at published job descriptions, no two descriptions are alike, right? Do they have privacy obligations? Are they only responsible for Medicare and Medicaid? Are they also responsible for, corporate compliance and oversight? So people's experiences with compliance leaders vary. So I'm not sure how much misunderstanding I could opine on. Really, as mentioned before, sometimes compliance leaders who are the embodiment of the Department of No, that can be discouraging, and then folks don't want to work with that partner anymore, and we end up working in silos and not having a seat at the table. I would point to recent Department of Justice settlements or corporate integrity agreements. The fact of the matter is that sometimes the wrong people are in compliance leadership roles, or their program is ineffective. There could be so many factors that landed an organization into the spot that they are. But whatever you're doing when you're working with stakeholders, either in compliance or operations, we have to listen. We have to seek to understand their pain points and goals because they're very different from ours. And if our partner doesn't feel heard, then you're not going to have a lot of success.
Yeah, that's well said, Regan. Just piggybacking on that, probably this is a good transition into Medicare Advantage rules, right? So just stepping back on what is going on, right? So there were a lot of new compliance rules that were published. I know you and the team in navigating several health plans and organizations within the industry, helping them. And then we also have later in April, the final rules for calendar year 2027 to be published. So there are a lot of new rules in place that needs to be operationalized, and there are other rules that needs to be finalized for the future. It's a lot of parallel tracks. It's the usual cycle of changes, right? But I feel like there is a perception and there's a lot of regulations that could limit performance. So from your perspective, practically speaking, what can Medicare Advantage plans actually do today with current compliance rules and also to improve outcomes? What are some practical mindsets people can apply right now?
What people can apply right now is the behavior of engaging in conversation, not just with the regulators, but with their trade associations, with other partners in the industry who have the same pain points. When CMS invites public comment, we have to give them. If they don't know, then they won't have a justification to move in any particular direction. For example, Subbu, I spoke with CMS marketing leadership after they had finalized the requirements that agent and broker sales calls needed to be recorded. And what they told me, as well as a group of other peers in the industry, is that they didn't hear a loud, CMS did not hear loud opposition to the recording requirement. But once it was passed, then plans came out of the woodwork to say how much storage these recordings were going to take, how much burden this was going to put on their organizations as well as their agent and broker partners. So it's important to give comment when CMS does request comment. I also think that it's important to encourage innovation. Even though we're not the experts of every operational area, it's important to be curious and ask questions. Earlier this week in our own leadership meeting, I asked questions, without any hesitation of looking uninformed, but I have to make sure that I stay inquisitive and stay engaged to grow my own understanding of what plans are doing or what we are doing in leadership. So that helps me understand how I can best support, the organization, myself. And that's how compliance can do so in their own strategic conversation.
Yeah, that's awesome. You mentioned innovation. I don't hear too many people on the compliance side in general, like, innovation and compliance, right? So it's awesome you mentioned that, and that mindset is so critical. Regan, I was there at the CMS Quality Conference a couple of weeks ago in Baltimore. I can definitely sense the kind of urgency in terms of change needed and a new mindset needed. That's probably also, really cost is rising so fast. Like almost every health plan struggling with medical cost management in general, right? Especially on the MA side, and a lot of things going on the AI side of things in terms of trying to, organizations trying to operationalize within the context of compliance and security and all that stuff, right? So there's still, there's a lot of innovation needed. I was encouraged to kind of see like in an innovation mindset. I'm still waiting and watching from a CMS perspective, but I was definitely encouraged to see the innovation mindset. I know you said it well in terms of really thinking about if you have ideas, share it, with the regulators and continue the conversation. But with all these things going on, what are three action plans that can be taken right now that could be both meeting the compliance and the intersection of improving performance from a population health outcome standpoint? So whether it's clinical decision making or prior auth or stars risk adjustment, any 2-3 things that actions you think that's in the intersection of compliance and performance?
Sure. Monitoring the clinical decision-making of delegates has always been a top priority for CMS, especially since it hasn't left their program audit protocol in quite some time. That's really important. They continue to have findings, and demonstrating that you are monitoring that is really important. There are some delegates that have really great controls in place and their criteria checks the box, but there can be misses with other delegates, and making sure that there are key performance indicators in place that you determine on that cadence, like how are you monitoring that? Is it effective? Are you identifying areas of opportunity? Does someone need coaching, a particular medical director? Monitor that clinical decision making of delegates. I would say make sure that those things are in place, and then you can determine what prior authorization rules maybe you can reevaluate either mid-year or at the end of the year. A lot of times our evidences of coverage are submitted and the bids are submitted stating, prior authorization may be required. So that gives you a lot of latitude if you want to relax some prior authorization. It's the opposite when you want to implement new prior authorization, but relaxing it is the direction that CMS has all but come out and said that they would like plans to do. So that would be my number one action plan, is to really focus on that, especially with CMS asking plans for so much more reporting of this area. What can we do to relax it? What's really not needed in terms of prior authorization anymore, because things are getting approved all the time? Where's the value? The second thing I would recommend, Subbu, is in the special needs plan, model of care implementation. So monitor that steps are being followed according to the model of care. CMS has communicated to plans that they still see plans struggling with adherence to their submitted model of care. CMS publishes, or NCQA publishes, all the scores for models of care, and that's great when you have a top score, but is it implementable? Can you operationalize all those steps? Is it reasonable for your population, for your employees, for your delegates to administer? That's something that CMS looks closely at. So if you have committed to doing something and you find that something's not very reasonable, it's important to start redlining your model of care and putting that into place to determine what's reasonable, so those members can have the right steps implemented for them and their unique needs.
That's awesome. Top two for people who are listening, right? Clinical decision making, same time having the monitoring really tight and also agile in a way. And then SNP model of care. It's interesting. These two, although Regan, it sounds so basic, but it's so direct patient care and population health management. All right, fundamentals of population health management. I remember SNP model care. Sometimes it's easy to get the score first, right? You can get score really high in terms of points, but the model of care, only few functional areas I see within organizations, whether it's compliance, quality, and perhaps some of the clinical, folks look at it really closely. But what you mentioned, this is how you're managing the population, right? You're not only putting it in the document, but it's really a population health management structure, right? So it's awesome that you double down on that as like a, top priority, which is close to my heart in terms of really managing the population in a way. So with these top two, let's talk about how functional areas and teams can coordinate with compliance, right? So one of the biggest friction points I see, some teams, whether it's risk adjustment teams, compliance teams, risk adjustments, take as an example, right? It has so many nuances in itself. We've created this complex system over time. I'll tell you, CMS also accepted that, right? It's gotten so complex, and for various reasons, right? So it gotten so complex, and CMS, quick plug, they're actually looking into a new model and seeing how new models can be implemented in the future. So a separate discussion about that. So not all compliance functional leaders really have to understand all the details, of risk adjustment, right? So I see constantly, there's also in my experience, there's a constant interplay between okay, understanding an issue. It's hardly many are on the same page, except for the dates. You need to kind of hit the dates and all that stuff. With that being said, what are some best practices in your opinion as a compliance leader? How can we remove those silos and really have compliance and risk adjustment teams complement each other in a really nice way? So would love to hear your thoughts, because with RADV coming, dropping even more, I think the function of compliance becomes even more critical now in risk adjustment.
Oftentimes, compliance and risk adjustment do not report up to the same division. And so you already have an organizational silo. So similar to just working in life, working with D-SNP beneficiaries, working with your risk adjustment leadership partner, you have to meet people where they are and understand what their needs are. So just like life, if you don't communicate, if you don't understand their pain points, then what's going to happen when you're in your compliance role and you're reporting up, you might be sending mixed messages to your divisional leadership, and the risk adjustment team or the risk revenue team is communicating their risks and pain points. That could lead to a lot of leadership discord, and we're responsible, at least in compliance in that second line. We are responsible to monitor and oversee and make sure they feel supported. And so if a compliance team is regularly reporting and it's not including RADV audits in that conversation for Medicare Advantage or HHS, regardless of what it is, they are very, very important. Then it's possible the risk adjustment team, they could miss out on the opportunity to get more resources or attention on their lift, because we're absolutely seeing a lot of pressure put on those areas as well as on the providers. So that's why it's important that even though the compliance professional may not be the expert in their obligations, they have to understand what their obligations are, not just timeframes, and also what some of the consequences are of not meeting those obligations.
Yeah. And Regan, let's talk about the consequences on risks, right? And I can see from a risk standpoint, whether it's risk adjustment or stars or quality, right? So the risk is really not having enough firepower. Let's call it, for lack of a better word, in terms of getting resources needed to meet certain star measure, thresholds to kind of really impact overall stars, or it could be RADV related resources. Those are two things comes to my mind, from a risk adjustment and star perspective. What are the risks comes to your mind from a compliance perspective as well?
There's a ton at stake. We can look at past audit results that CMS has recently published, and we can see the disparity between some of those data points that were not validated and what some of the results were in terms of what CMS says plans owe. So we can see that, and maybe you can read between the lines to determine at that time how was their program, right? Because some of these results are quite dated. So that's a risk in because every chart matters. It really does. The integrity of that work is so important. And, compliance doesn't often get involved in the immediate everyday oversight of risk adjustment. Most industry best practices show that at the first line, the risk adjustment team implements some monitoring and auditing because it's so specialized. It's not something a compliance function or a compliance divisional leader has the resources to employ someone with that kind of specialty. They can certainly hire someone, but usually that happens at the third line in internal audit. So it's really important that compliance still be a part of the conversation and not skipped over between first and third line. I think about OIG and their recent reports that they've released. And you and I could probably talk about an hour about the
Yeah,
differences between how OIG audits and the differences between how CMS audits, but we won't go there today.
right. Totally. Yeah.
But they recently released a report. They were talking about a plan, and the plan had a number of procedures in place and steps in place designed to ensure that their diagnosis codes comply with federal requirements. So
Mhm.
even OIG acknowledged specific things that they had in place. However, the outcome of the audit was still quite unfavorable. And so OIG or any agency could draw conclusions and recommend examining existing procedures. So they could acknowledge, yes, you had these steps in place, but were they effective? Again, methodology aside, it's a statement, it's public, it's something we can all look at to determine where can we improve ourselves.
Yeah. Totally. Speaking of improving ourselves, so if I'm a Medicare Advantage leader right now, right, in sitting in a health plan, and for example, payment year 2020, RADV was selected on April 3rd, as when this podcast is released, the enrollee list will be out. And the subsequent cycles for RADV will come out. If I'm a compliance leader or a general leader in a health plan sitting at us, like, I want to fix this, right? So in the next 90 days, we can't fix everything right away, right? So it's a number of years of fixing. Let's chunk it a bit, right? So this is generally the approach we take. Like, what can we do in the next 90 days? Where should people start?
People should start, they shouldn't wait for any new audit notice or something else to happen, but they can start right now with a number of different things. And actually, I talked a little bit about this in a recent post while you and the team were at the RISE National Conference. So I know you brought back a great deal of wonderful information for us to understand and learn. But, as I was at home here manning the fort, I
You
looked
were
deeper.
manning the fort really
I
well.
was. One of the things I recommend folks do, I don't want it to sit quietly on a shelf, but look deeper into the OIG's Medicare Advantage industry-specific compliance program guidance that was released earlier this year. OIG themselves, they didn't create this out of nothing or at the side of their desk. They interviewed industry stakeholders, actually responsible for the work or overseeing the work. And they made some specific recommendations regarding the oversight of risk adjustment because they acknowledge that this is a risk in the industry. And keep in mind, these industry-specific compliance program guidelines, they just got a major overhaul, because it was a couple decades old. So if they recommend something broad, take a look at it, but look deeper into the recommendations and determine what can you do for an organization your size, whether you're small, mid-size, or large, because not everyone has the same resources. For example, a broad recommendation, OIG says plans should educate coders, providers, and FDRs on proper coding practices. Subbu, it's easier said than done, right?
Easier said than done. Yep. Mm-hmm.
What can a small plan do versus a large, national plan? What can they do to have effective training? One of the recommendations that I would say, because the compliance function has to have effective training in place, they've had to have, effective is part of that word, but they're not saying have effective training here, but it's implied. So what kind of techniques do strong compliance programs implement to make sure their training is effective? You could do attestations, you could do brief tests, you could make it fun, you could do micro trainings. There are a number of ways to get creative in that space because effective training looks different by your audience, the subject matter, and the organization. Last but not least, I would say document those efforts because one of my old mentors said, if it's not documented, it didn't happen. And I think that proves true for everyone. So that would be something I recommend is look deep into those recommendations. And then the second thing to do is to take a look at those publicly posted OIG reports. They mention plan practices and they make recommendations for additional activities. So take those to heart as well and document those efforts to show that you're trying.
Well said. And with the age of good summarization tools out there, right? It's important to also read the entire thing, but also look at the patterns, like you mentioned. Right, there are some implied things. I think that was an important thing I took away from what you mentioned. Is there are some of these recommendations may sound check the box, looking at what is really they're implying as part of that, making it effective. Something that I took away from this, Regan. So thank you for that. So calendar year 2027, it's right now, we're always like operating right now and then
around the
planning
corner.
for future around the corner in terms of calendar year 2027 final rules. I know you've been digging into the trends around public comments. There's been a lot of comments out there when CMS released the advance notice. What are you seeing? What are the themes that you're seeing from your perspective?
What a lot of reading that CMS gives us in publishing those public comments. I have not only reviewed comments from trade associations and plans, but also from some delegate and vendor partners that have provided great comment about the proposed regulations, as well as responded to CMS's request for comment on certain things. And in terms of future direction, what I've seen is that the trade associations are generally supportive of streamlining or removing any burdensome regulations in order to strengthen the program. So they're putting CMS's words right back into the ether to acknowledge that is the goal. There's also a call for adopting transparent and phased approaches to any major changes to risk adjustment. They want CMS to give stakeholders time to preview and test any changes. So I think that's important and they might take that to heart as well. Plan comments have some common themes as well, generally supporting sales and marketing requirement changes, streamlining of star ratings, the removal of the HEI. And then within plan comments here and there, you can see where their priorities or their pain points are. For example, I'll give you translation requirements. That's been one thing. I think there's a proposal to remove the multi-language insert and defer to OCR's, published document for language translation and support. One large plan supports the removal of the MLI, and another plan that's also large does not, and it's almost the opposite direction. They bring data. CMS has said before, give us data. You have to give us information that we can respond to. It can't be anecdotal. So if something we're proposing is going to incur more resources or, cause you to have to, make major changes or expenditures, they need to know that because they're making assumptions on a lot of things. So some plans that have that information, they have been sharing that.
Interesting themes. Interesting themes. People are engaged, which is awesome. And thanks for that insight, and Regan.
I have
So,
one more thing
yeah,
that I did identify. Something
please.
CMS asked a lot about wellness and nutrition. And what is the future of CMS's guidance regarding wellness and nutrition? That's been something that I've been personally following with the
Mhm.
administration,
Yeah.
with CMS launching SSBCI. Where can we get creative in terms of some of those benefits? Some of those delegates I mentioned that provided public comment definitely support it, but it has to be partnered with some sort of behavioral health, right? Because simply providing, the nutrition may not necessarily, on a standalone basis, be the cure-all for changing behavior, whereas behavioral health partnered with that could change it. So I thought that was very interesting. And when the administration gave states the leeway to tailor their SNAP benefits to be a little bit, they could eliminate certain items. Uh, that was an indicator for me about the way that things might go. We haven't seen a lot from CMS about it yet, but when they
Mhm.
mentioned healthy food in a previous rule, but they didn't define it, and they leave it to plans to define it, and now the administration, has given states the flexibility to tailor their SNAP benefits. I wonder if that's something we might see from CMS in the future.
Yeah, yeah. Certainly, the food side of things, we have a lot to kind of like lots of opportunities there, depending on people's political affiliation, right? It could be very sensitive, with the way things are going. But at the same time, I'm a glass half full kind of guy. So I think you are too. So like, whatever we can do to kind of really put the conversations around healthy food and really do something about it, I'm encouraged, and we'll see what happens. For folks who are waiting for the final rule, we're all waiting for the final rule, but at the same time, we're acting, right?
Right.
So what is the risk of a mindset that, okay, we'll wait until we act? What can people continue to do? Right. I mean, some things I understand, like, implementation of a new, I'm just making this up, right? A new star measure, right? So we have to be prepared, and then we have to, once CMS confirms it, you go, right? But what's the right mindset in your opinion? What can people do right now while waiting for confirmation from CMS on the final rule?
If folks are in a wait and see mode and remain stagnant, they do risk falling behind in their measures, in their performance, in their member retention. And so it's just a mindset that folks should evolve away from. There is infinite opportunity to enhance your program while we're waiting for CMS to confirm their direction and let us know what they are thinking about in terms of finalizing in their 2027 rule. One example I'd like to give is that CMS has said very little about artificial intelligence. We have the executive order, we have a clarifying memo that CMS released regarding the use of AI. And we have a regulation about medical necessity, and we have to make sure a human is involved in those denials, especially adverse decisions. So since CMS has said very little about it, there are so many ways that there are solutions out there that could help streamline beneficiary service, access to information for them, They are much more technologically savvy than they were 20 years ago. So what kind of functionality can be implemented to help them get their information and get their services in a more expeditious manner? Think about implementing solutions for your associates. Like, what can make the employee experience better to service those beneficiaries at plans? I recently read a Compliance Week survey that said that 83% of compliance professional respondents said they are starting to use AI. So I think that's really promising exploration, not only for the compliance function, but for all of operations.
That's great. So let's transition into special needs plans. Regan, this is a tough population, both whether it's ISNP, dual SNP population, and DSNP, so SNP plans have been one of the primary reasons for overall Medicare Advantage growth, compared to last year to this year, right? Because there's been a lot of shakeup. It's a whole conversation in itself, right? But with that significant growth in special needs plans, compliance and operations needs to be very tight, apart from clinical work that needs to be done, for that really needy population, right? What makes SNP plans fundamentally different from a compliance standpoint, in your opinion? And where are plans struggling right now as they scale offerings for SNP kind of plans?
Special needs plans can't be looked at as just one PBP in a family of PBPs under a contract. It is so unique. The population is so unique. Their needs are so unique. What we're doing when we have a special needs plan is that we are making an above and beyond commitment to those members. They are very high touch. They have very bespoke requirements that need to be understood and then, worked through in partnership with that member, in partnership with that member's care team. It's such a unique model, and plans have a really great opportunity here to go above and beyond. The plan structure, the plan requirements are also augmented. They have a requirement to have a membership advisory group. So, for example, hearing the collective feedback of membership, asking what works, what doesn't, circulating ideas about potential changes, what might suit their needs better. That forum is not a requirement of general Medicare Advantage plans. So that's an untapped resource for standard Medicare Advantage that special needs plans have in order to help tailor. And what we hear in Connecticut or Rhode Island or Pennsylvania is going to be different than what DSNPs here in Florida and California. The communities are different. The population is different. So it's such a high touch and, high requirement. They need operational and leadership attention and resources in order to be successful. I find the top plans are almost acting like a community-based organization with insurance wraparound, right? It's really high touch, and you feel like you're part of a community if it's implemented very well.
And I know historically, you mentioned about top plans, high performing plans, right? So really entrenched in the community is a great way to go, but it also adds a lot of investment, time and resources, etc. Right? So if I'm a stars leader listening to this, right, getting high performance and star ratings in SNP is really hard. One of the hardest, right? So for folks who have done it, consistently year over year, over 4 stars, kudos to you, right? Same time, we spoke about all the kind of dynamics of the population and how people need to be structured in an organization. But from a star perspective, what are the best practices that you've seen, and what do you advise, right now to help plans broadly to not only optimize like whatever you need to do in the community, be in close touch with members, that makes sense, right? But at the same time, when it comes to metrics and it really kind of improving those metrics around stars, what are the best practices that you see?
A few that I can list off, and I'm by no means a stars expert, but meeting people where they are is going to be a huge advantage. Transportation, for example, is such a huge barrier to probably, might be one of the root causes of closing some of those gaps, right, Subbu?
Mhm.
If they can't get to an appointment or they can't go get a test, that is a failure in so many aspects, right? Either their community or it's rural or there's just not an infrastructure in order to cover something like that. What I can see that plans can do is seek out those community organizations that also have something very mission driven where they can provide some transportation or the service can come to a site in order to close some of those gaps, because it might not be because the beneficiary doesn't want to go get the service. It's just a lack of transportation or ability to do something. One thing I do see a lot of really community-based federally qualified health centers expanding their scope of service, including transportation. Is that something that payers can explore with those provider groups to see, what can you do with your population in order to support our mutual goals?
Yes. Yeah. So many people in the mutual goals is like a very highly underutilized strategy in a way. I feel to your point, right? Because many organizations are driven, especially from a community, perspective. They have their goals, right? And meeting them, really trying to drive the outcomes for the members in a very coordinated way it's easily said than done, right? In theory, yes, yeah, like, let's mutually align and like, go at it. But it takes a lot of hard work, having that conversation, partnerships, knowing the population, knowing the zip codes, knowing what food's available, what transportation is available. It's a lot of hard work. But there's prioritization involved, within there, especially from a star population health perspective, right? Regan, I want to transition this to the prioritization part to what you do, as ATTAC Consulting Group within your practice, right? So right now, folks know, people who are listening, I lead the stars and risk adjustment, part of the consulting practice within ATTAC. Regan and I partner with you on the compliance side. We talked about, a lot of things. What can people do in 90 days? How can people interpret this compliance rules? What are the different action plans that people can do? So tell us about what are the top things that you offer, for organizations, within your awesome team that you have, so that listeners can understand how they can get help from you.
Of course, we have a wide array of subject matter experts, not just in corporate compliance and ethics obligations, but also operational experience, from enrollment to grievances and appeals to claims and care coordination. So we field a number of different requests from folks that have most recently perhaps lost staff. Right, resources are being evaluated at a number of organizations, and they're seeking some consultant help to either support a process improvement or meet a regulatory obligation to conduct an audit or to supplement their own compliance audits. So we start there. There is such a continued stream of regulatory pressure, but they're working with fewer resources, and so that's where we can come in and help. One thing I mentioned earlier was about listening. We also listen to identify if there are other issues going on, because that compliance counterpart we work with is typically either very involved in operations or they're not involved in the conversation. So we always recommend that they do ask and be curious and involve themselves. But if they aren't, then, we can ask them some key questions to see if there's any other way that, such as your practice could support or give some guidance, or just hop on a call to say, let's have a 15-minute conversation about an issue you're having, and we can let you know what we're seeing. So it's about being a good, flexible partner.
Yeah. you are one of good partners, for our practice, Regan. I think just peeling it back a little bit, right? So, right, sometimes it needs a whole different kinds of expertise to bring together a solution for a health plan or a healthcare organization, intersection of compliance, which you and your team are fantastic experts on all the things that we talked about from a RADV perspective, and stars, just like always a compliance angle that comes to it. And also this provider network management, we have a whole provider network management group that comes to it. It's awesome. It's like almost experts of experts coming in together, to help plans. But what types of organizations, if you can, I know we talked about health plans and general Medicare Advantage plans, but if you could just talk about what kind of other organizations you're also supporting, would be great.
Yeah, for sure. So a common term in Medicare Advantage is first tier downstream and related entity. So we also support FDRs as they are supporting their payers. So that's something that we really value as well, because they want to be good partners as well and not only meet their service level agreements, but also their compliance obligations. So we really enjoy those partnerships to support them. That's a really good partner. We also have supported ACOs. So that's also very important and something that, they have different compliance obligations than a plan. And so it's really important that we have a good understanding, a solid understanding of the distinction of where their higher risks are. And that way we can support them in meeting their goals, enhancing their compliance program and their obligations.
Great. I know on the plan side, you're also supporting SNP plans, and I'm excited to kind of be part the speaking panel with you, in July in Virginia for the SSN conference. So people who are coming to the SNP Alliance in a conference in July, reach out to me and Regan. Would love to talk.
Sure, that's going to be an interesting conversation. There are a lot of different speakers talking about all different aspects. So not just regulatory compliance, but also what's effective, what's reasonable, what can be implemented. So I think I'm very excited to hear some actionable takeaways from that event.
Awesome. So, Regan, I'm going to move away from the compliance and the healthcare side into leadership, right? So you've just been an amazing leader, in this space and overall in different organizations that you served, right? Both on the consulting side and also on the health plan side and all the other organizations you started off. You mentioned about member-facing roles that you had. I think it's an important kind of experience to have, for empathy and understanding, and meet people where they are. So you're also developing next level leaders, right? Right now with your team and others. So you've developed many leaders in your career. What defines a next level leader in today's healthcare environment? If somebody wants to be Regan Pennypacker in the future, right? What are the steps that people need to take to become a better leader in the space?
Yeah, great question. And thank you so much for that nice accolade. I do my best. I think one of the most important things about being a next level leader is being self-aware. And I do my best on a daily basis to make sure that, I understand where my strengths lie and where I need a little bit more support or information in order to make really well-informed decisions. So with that, when I go into my day, I also want to make sure that I continue to be proactive and innovative. You mentioned earlier you don't hear compliance talking about innovation too much. And where compliance maybe in the dark ages was the department of no, you can't do it, how do you get to yes? That's a good compliance partner. Okay, maybe you can't do that, but what can you do in order to achieve, what you want to do? So it's a ongoing conversation, and it's helpful to keep the ongoing conversation with your partner to build that trust. Come to the table with ideas. It is certainly a great conversation starter to say, we'd like to do this to close some gaps. Is this permissible within the guidelines? that's your role because you've probably both reviewed the guidelines and you want to make sure that you understand them really well. That kind of collaboration and inclusion and that mutual consulting with the right stakeholders, that helps you make good decisions and helps empower you to take really smart, well-informed risks. Because there might be something you want to try that is pretty much within the guidelines, or maybe the guidelines are silent about it. I think having that optimism and looking at your shared mission will help you achieve a good relationship in terms of leadership and long-term organization success.
Yeah, those are some great tips, Regan. Last question. We haven't spoken about AI. So what's a podcast if we don't speak about AI? Just joking, right? So in the age of AI right now, a lot of changing expectations, a lot of learnings. The way we work, the way we operate is dynamically changing. How can compliance leaders and operational leaders kind of adapt to this change, especially with I feel, my personal opinion is I think the compliance leadership and compliance function is going to be even more critical with AI, making sure that, and especially in the healthcare setting, there needs to be proper regulation and like the way, AI needs to be looked at from a privacy and also compliance standpoint. What are your thoughts? How can people evolve? How can people learn? How can people adapt?
In my discussions with compliance leaders about AI, there's a focus on establishing and maintaining AI governance. So that's a priority for most organizations. And one thing I strongly encourage is to include an ethics voice in governance. The NIST's govern element is the foundational pillar alongside map, measure, and manage. So as part of govern, it's designed to ensure AI adoption aligns with legal, ethical, and organizational safety standards. In 2024, compliance leaders were being asked by CMS, what do you have in place at your organization? And they didn't always have the answers. They had to go find them rather quickly if they weren't part of the implementation or the approval or the rejection of any AI solutions. So compliance has to be fully aware of what's being in place, what's being put into place, and what's being evaluated. I talked a little bit earlier about 83% of survey respondents of that Compliance Week survey said they are using AI, but only 25% of them indicated that they have implemented a strong governance framework. So that's kind of alarming. You can see how fast-paced the implementation is and where you can keep your finger on the pulse on where governance is. So that's really important, and that's going to be something I anticipate that leaders are going to continue to discuss throughout 2026.
Fantastic. Regan, I feel like we can cover even more topics, more than this. This has been a fantastic conversation. Thank you for your insights, right from CMS final rules to AI governance, to some of the frameworks, some of the priorities that you mentioned, for SNP plans and other plans, and also talking about your own story and also connecting the dots, also mentioning innovation and not only mentioning, but also really giving ideas about how to innovate in this space. So thank you so much for being part of the podcast.
Thank you so much. I've really enjoyed the conversation, and I hope we get to do it again.
Yeah, sounds great.